Right, so this morning what I thought I'd do is actually get into our back pain stuff. So I don't know how I fell into back pain. I know my wife injured her back in about 2001, and she was at a stage where she got a bulged disc, she couldn't walk, she was in constant pain, she could hardly move. So we started on a rehab program with her, and within 6 months we had her functioning normally, and she was pushing over 300 kilos on a leg press again. So it sort of allowed us to really understand how to rehab back pain. And when we look at back pain, there's really only two things behind back pain. There's either structural problems or functional problems. And a lot of physios and chiros go to me, you can't make it that simple. And when I say to them, well, is that wrong? They sit there and go, well, no. So either a structural problem is something where there's structurally something wrong, like you've got a prolapse disc or a bulge disc, an extra vertebra, a fusion, spondylolisthesis where it falls forward, or a stenosis where you get a narrowing of the spinal canal. Okay? Or it's functional where you get muscle tightness, there's postural imbalances, or potentially neuromuscular activation issues. And there's other things there. But the big thing with this we wanted to point out is you actually can't really fix a structural issue. You can fix a disc bulge. If anyone's got a disc bulge, we can easily fix a disc bulge, okay? But we can't fix a lot of these structural issues. So what we really want to get across to clients is we need to actually strengthen, maintain, and manage. And we have a lot of clients who do have disc bulges, who do have major problems that live completely pain-free. Okay? The great thing about functional stuff is we treat it, we strengthen it, and we fix it. Okay, so when we start looking at these two areas, you know, this determines my language when I'm talking to people, because if I'm living in this world, all I want to do is talk about how we're going to fix them, because I've got to get them thinking that way. If I'm talking about this world, I've got to talk about strengthening and managing. So obviously one of the biggest things with back pain, like with any disease, is the client can't let the injury own them. How many of you heard people say, I am a diabetic? Well, when they say that, they're always going to be a diabetic because they're letting the disease own them. All right, so up you come for me, Dan. We'll start with you. So we're going to use Daniel and Mark today. What I wanted to do is, and it's really hard to do this in 10 minutes, so if I'm going too quick, just hold on and you can ask questions later. When I see someone, what I need to do is I need to look at the whole picture. Okay, and did any of you hear the Australian cricket physio yesterday say Michael Clarke's back injury has got nothing to do with his hamstrings? That guy should be sacked. That is the biggest load of crap I have ever heard come out of a physio's mouth in my whole life. Because the symptom is not always the cause. Okay, just get you to turn around. We have these things called muscle slings. Okay, it was developed back in the 80s by a guy named Thomas Meyer. This muscle attaches to this muscle, that attaches to this muscle, that attaches to this muscle, and so on all the way down the body. If you think of a train, what happens if this carriage doesn't work? What happens to this carriage and this carriage? They have to compensate and carry it, don't they? Now, Michael Clarke's had a back injury for how long? Yeah, right, so he's got a problem here. So that means that this carriage and this carriage are overcompensating and helping him. And they've been focusing on strengthening this, and I can guarantee from looking at him that they haven't focused on strengthening his glutes. And that's what's happened is he's gone and run, his back's now weak, his hamstrings have tried to do all the work for him, and hence now he's got a hamstring problem. Okay, and the reality is 95% of people I see who have what we call idiopathic back pain, they can't understand what it is, so you think they're an idiot, they think they're an idiot because there's no reason behind them having back pain, okay, is muscles aren't working properly. How many of you sit down for more than 8 hours, more than 8 hours a day? You sit on your butt in the car, an hour and a half in the morning, hour and a half on a night, going to traffic, sit down and work. What happens is your glutes stop working. And when your glutes stop working, you start carrying more stress and more tension here, more stress and more tension here. If you're a football player, you'll end up doing a hamstring. Okay? If you're an office worker, or if you're overweight, or if you do a lot of bending, your ass. Okay? And you do a lot of bending, then it's likely to be the back that will go. Very, very rarely do I find people who have chronic back pain, glutes will fire. So we've got to look at the whole picture. The other big thing that comes out of looking at the whole picture is leg length. Okay, so just jump up again. You've had knee surgery, so we should see a difference here. One of the things that we look at is when we're assessing someone is we always have a look at their hip height. You see, what happens is the hip joint is a ball and socket joint. It sits like this. And if you, say for example, play football, or you just run down some stairs trying to catch a train in a hurry, and you jolt down, that hip joint can go like this and the other one can stay like that. And that then leads to a discrepancy in your hip height. If you get a discrepancy in your hip height, so this, and down here you can see this hip's higher, these muscles tighten and shorten. Because unlike this cable, when 2 points come together in a muscle, they don't go like that. The muscle just shortens and it tightens. Okay, so that tightens here. This gets weak. Okay, this turns off. This turns on. All right, this carries more weight because this side here is longer. He compensates by shifting, and we have now back pain. All right, and as a physio, if I go, oh gee, as an allied health professional, I won't pick on physios, he'd sit there going, oh yeah, we need to loosen this, and we don't look at the leg length. What's going to happen as soon as he goes back outside? Exactly, it goes back. So we might get 4 to 6 weeks out of this, but then what happens is it comes back and they come back in. So one of the things, thanks mate, one of the things we want to look at is why do people get back pain? Mark, do you want to come up next? Okay, so Mark has back pain, I believe, at the moment. Okay, and Mark does Pilates. So you know that wonderful world of clinical Pilates that everyone says is fantastic for curing back pain. Most clinical Pilates is done on the floor or on a reformer. Very rarely is it done in this position. Okay, and this is where clinical Pilates stops and you've got to meet actual rehab and strength training. Because at some stage you need to get up and walk. Okay, when we have a look at Mark and we assess Mark, you'll notice here, Mark's actually quite straight through here, but his pelvis tips forward. So if you imagine he has if this is a cup, okay, and his pelvis is tipping forward, you're going to pour the water out of the front of the cup. That's called an anterior pelvic tilt. If he tucked it the other way, which he can't, okay? If he tucks it the other way like this, okay, that's a posterior pelvic tilt. What happens when you have an anterior pelvic tilt, and from sitting down a lot and arching his back to sit up straight, because you have to sit up straight at your computer, we get an increased curve here. These muscles then tighten. This tightens, and the muscle at the front here called your iliopsoas that comes out through here also tightens. That pulls forward and this pulls back, so you end up with this excessive curve. When this gets tight, the abdominals get weak. The glutes get weak, the hamstrings get tight. Have a look at Michael Clark's curve in his spine. You can't tell me his hamstrings aren't causing a problem. Okay? What tends to happen here is if the glutes don't work, we have 3 major arse muscles, John. Okay? We've got the big one called gluteus maximus, then we've got gluteus medius and gluteus minimus, and then we have another muscle on the side called TFL, or tensor fasciae latae, commonly known as the coffee muscle to students who do want to learn it. Okay, then they remember it. If glute max stops working, which I can guarantee in 80% of the room, your glutes won't work. You'll have what we call SAS, which means? Saggy ass syndrome. Okay? Unless, of course, you're over 55, then it's called glute amnesia. Okay? What happens is these 2 muscles here, these 2 smaller muscles try to do the work for the big muscle. This tightens here and here. That fires TFL, which causes the pull the knee here, creating knee pain. When you pull the knee this way, it turns on hamstrings. Hamstrings will tilt the pelvis, causing back pain. It will then turn off what we call the vastus medialis at the front, or your VMO muscle, okay? And that then leads to patellofemoral tracking syndrome, and now you've got a client who's not only got back pain, they've also got knee pain. Okay, thanks mate. So when we're looking at this whole picture, you can't ignore those things. Okay, I have a client who came in the other day. She was referred to me by Matt, and she was referred to me from someone in Queensland. So she said to me, I've been referred to you by 2 states now, so I should probably come see you. And she has had back pain for 4 years, painkillers every day. And one of the things I first looked at with her is, a lot of the time when we're doing high-end back pain, I'll give you a picture of the body, and I'll ask you to circle in blue anywhere you've had old injuries, and shade in red anywhere you got pain. Okay, and she had an old ankle injury. But, you know, no one ever talks about that. That was 15 years ago. It doesn't matter. The ankle is the connection between the floor and your body. Every time you go to step and you put your foot down, nerves fire in your foot to tell your hip to tighten up. We're about to have impact. So if you've rolled your ankle or you've jarred your ankle, okay, so when you jarred, you're playing footy, running around, jumping. So when I worked with Doncaster Footy Club, we had no soft tissue injuries for the whole 12 months I was there. 90% of the work I did was soft tissue stuff. was ankle stuff. So you've got two joints here. We've got what we call our tail crural joint, and we've got our subtalar joint. When these joints lock, they lock your hip. Okay, so if you lock your joint in your ankle, and if you don't have full, what we call flexion down, plantar flexion and dorsiflexion coming up, okay, if you lock that up, that locks your hip. Your hip locks up, tightens up through here, and that rotates your pelvis, then leading to tightness and more problems through those glutes areas. So, you know, in trying to cover this topic, and I said to Ray yesterday, it's such a big topic, and she goes, remember, less is more. So I thought, okay, leg length, hip, ankle. And trying to treat people, this is my model of rehab, and I'm actually in the process of actually launching this into a course for my industry and for the allied health industry. The first thing we do when someone walks through the door is we assess them. And we've got to walk them through where we're taking them. See, this is what most therapists do. Massage, physios, they treat. Okay? This is what chiropractors would say they do. They mobilise the joints and do subluxation, which helps with the neural stuff. Okay? Physios will say they do it all, but that's debatable. Okay? Then you've got these other things here, stretching, specific rehab stuff. So what we do is we take people in, we assess them, and a lot of the time when they come in, I have to massage or treat them, and then we reassess them. So how did that respond? From there, I need to decide, what do I do next? Because if I just massage them, I'm going to keep seeing them over and over and over and never fix them. And this is the power of exercise rehab. So then I might get their joints moving. We might mobilise their spine. We might mobilise their pelvis with something like this, or with the strap. Okay? We then get the glutes working. We get the hamstrings working, and everything firing in the right sequences so the body's functioning correctly. And then we just keep working through this circle until we get them to here. And that's where we now actually need to keep them training, to keep them moving. The biggest thing you need to understand, and as I wrap up, is the body is designed to move. Okay? And if it's not moving, then you're going to get dysfunction. Now, I put this slide up for those of you who have seen me for massage and potentially can appreciate what this is, just as a bit of a joke. So that's sort of a quick 10 minutes on back pain and what I do and how I focus on working with it. Has anyone got any questions in the last 10 seconds?